My name is Michael Lübbert. I'm a hematologist from Freiburg, Germany, and will be presenting the results of the study just mentioned, 10-day decitabine versus conventional chemotherapy followed by allografting in AML patients aged 60 and older. And this is an intergroup study of the EORTC Leukemia group, CELG, GIMEMA, and German MDS study group. These are my disclosures. And what's the purpose of the research? Older, medically fit AML patients still represent a highly unmet clinical need because even if they receive standard intensive chemotherapy, resistance is a major issue, so the 5-year overall survival until now is less than 20%. Very often no successful bridging to the curative approach, i.e. allogeneic stem cell transplantation, is difficult or not successful. So the idea was to introduce DNA hypomethylating agents into this group of fit AML patients. You know that HMAs as monotherapy represent a milder AML treatment approved for medically non-fit AML patients, but alone obviously is not curative. So the purpose of the study to compare an extended decitabine HMA monotherapy 10 days to standard induction chemotherapy as two bridges to allografting in fit older AML patients. So this is the design of the study. 606 AML patients aged 60 years and older and fit for intensive chemotherapy were randomized. Half the patients received induction with daunorubicin and cytarabine, 3+7. 303 patients received HMA monotherapy, initially 10 days decitabine, down-dosed to 5 days, depending on the response. In both arms, patients were strongly encouraged to move on to allografting. No decitabine maintenance was allowed in the standard arm. However, for those patients not receiving allografting in the decitabine arm, continued maintenance treatment was possible. The study question, will we achieve longer or similar survival with a milder treatment, and will we observe reduced toxicity? And as mentioned, this is a multi-center trial in 8 European countries. The groups I've already mentioned. Apart from myself, Dr. Gerwin Hults from Groningen and Dr. Pierre Weiermans from the Netherlands served as coordinators of the study, which was supported by the educational grant from Janssen. Coming to the results, we observed similar overall survival in the entire cohort with a hazard ratio of 1.04 and a 4-year overall survival of 26 to 30%. And you see a plateau building here. Not shown is a similar outcome in terms of survival from transplant with a 4-year survival of 47%. We did observe fewer toxicities with decitabine compared to chemotherapy, which supported the long clinical impression of a different toxicity profile. So here, from left to right, you see the 4 most frequent toxicities: blood and lymphatic disorders, infections, changes in laboratory investigations, and gastrointestinal disorders. And you can readily see that 3 out of these 4 major toxicities were less pronounced with decitabine than with chemotherapy. And this was most marked for the gastrointestinal disorders, which were reduced by 2/3 with decitabine compared to standard chemotherapy. Notably, less time in the hospital was spent with decitabine. We observed an average reduction of hospitalizations by 20%. So, to conclude, 10-day decitabine provides a better tolerated alternative to aggressive chemotherapy in older fit patients, AML patients, with similar transplant rates on protocol and subsequent transplant of 52% in both arms. We saw similar survival with a hazard ratio of 1.04 and about 30% survival at 4 years, fewer toxicities, shorter hospitalizations, and better quality of life.